A very good evening to all. I cordially welcome you all to the fourth day of Pulmocon 2021. The topic to be discussed today is unmasking hypoxemia and two-chair test and its importance in clinical practice. To chair the session, I would like to introduce two distinguished faculties and eminent pulmonologists of the country, that is Dr. M.L. Gupta and Dr. G.C. Khilnani. Dr. Gupta is an eminent faculty with over 40 years of experience, and his area of expertise are ILD, COPD, asthma, and oral diseases. He is an eminent member of several national and international professional societies and is currently associated with Santokha Durlabji Memorial Hospital and Gupta Chest Clinic, Chairpersons. Dr. G.C. Khilnani is a consultant pulmonologist with more than 43 years of experience. He is the member executive council of Indian Chess Society and the chairman of Credentials Committee and Indian Society of Critical Care and Medicine. Currently, he is the chairman of PSRI Institute of Pulmonary and Critical Care and Sleep Medicine in Delhi. Both are a stalwart in their own fields and have several national and international publications to their credit. I welcome you, sir, and request you to presume over the meeting.
So, good evening, ladies and gentlemen. It's my privilege to be participating in this important annual meeting of Pulmocon, and it is my pleasure to introduce the speaker, Dr. Parthasarathi Bhattacharyya, who is doing his MD, DNB, and DM in pulmonary medicine, and is also organizing secretary of Pulmocon 2021. Dr. Bhattacharya is the founder secretary of the Institute of Pulmonary Care and Research, Kolkata, and is engaged in achieving the motto of the institute, that is research, education, and patient care with innovations. Research, education, patient care, and other activities. I have known him for 2 decades, and I've always been impressed with his interest in academics in pulmonary medicine. And today, the topic that he's talking about is hypoxemia, which has been a matter of debate. In fact, there's a paper in last 10 days, research paper in one of the most prominent journals, which said that targeting lower oxygen or high oxygen doesn't make any difference in the outcome. So I'm sure like this, Dr. Parthasarathi is going to teach us and tell us a great deal about the hypoxemia, and he will actually be able to unmask it to our benefit. So Dr. Parthasarathi, all is yours. For the podium is yours. Please teach us and tell us. Thank you very much.
Well, now we can just ask Dr. Parthasarathi.
Yeah.
You can start.
Right, sir.
Presentation.
So thank you, Chairman, sir. I'm really obliged to both of you. And basically, this talk has been inspired by Dr. M.L. Gupta himself. Last week, he had a wonderful presentation of 3 very important, interesting cases, and we thoroughly enjoyed them. I thought that I would be talking a few minutes after his talk last Sunday. But what happened, the speaker for today actually dropped out. So I had to expand my talk for today, and that's what I'm doing. Unmasking hypoxemia and the importance of two-chair test is my area of interest now. And in next 40 to 45 minutes, I'll be dealing with this. A lot of it has been inspired by Dr. M.L. Gupta, as you can find from the first few slides. And after that, I'll get into two-chair test and its applications. So what I'm going to deal with is a bit of physiology, including the mechanism of hypoxemia, measurement of hypoxemia and pulse oximeter, its utilities, unmasking hypoxemia, development of two-chair test, and utilities of two-chair test in both COVID-19 and non-COVID-19 situations. So let me start with the basic physiology, including the mechanism of hypoxemia. Our lungs are directly connected to the environment, and we breathe in about 10,000 liters of air every day. You can see that this schematically, the lungs are communicated to environment, And on the left-hand side, you have got right ventricle that ejects blood, which passes through the lung to the left atrium. On its journey, the deoxygenated blood gets oxygenated. And this oxygen is available from the air breathed in. So lungs
Slides
play
are
very
not there.
important.
Screen share.
Right, sir?
We are not able to see the slides.
Sir, screen to share code.
Kaushik, can you hear me?
Yes, sir. Yes, sir.
Am I audible and screen is shared everywhere?
No, sir.
You
are
are
audible,
audible, but
not
the
visible,
slides
sir.
are not there.
Screen is not visible.
No, sir.
Yes.
So let me start afresh. Thank you, Chairman, sir, for your brief introduction. And in fact, this talk has been was meant for last Sunday, where I thought that I'll be talking a few minutes on this issue after Dr. M.L. Gupta's discourse, but I had to drop it because my today's speaker is not available, and I had to expand my talk for 40-45 minutes. So it is largely encouraged by Dr. M.L. Gupta. And what I have decided today that I'll be talking about physiology, including the mechanism of hypoxemia. I will take a little course on measurement of hypoxemia and pulse oximeter, its utilities. Then I'll be talking on unmasking hypoxemia, development of the two-chair test, and utilities of the two-chair test in both COVID-19 and non-COVID-19 situations. Let me come to the basic physiology, including the mechanism of hypoxemia. Our lungs are directly connected to the environment. And in this schematic picture, we can see that from the right ventricle, blood is ejected through the lung and reaches the left atrium, being oxygenated. And the lung does this job. It inhales and exhales 10,000 liters of air a day, and the whole cardiac output is perfused through lungs. On the way, it exchanges oxygen with carbon dioxide and supplies fresh oxygenated blood to the left ventricle so that our body is fed with oxygen, which is essential for life. Oxygen is the pranavayu for us. This is the same thing, but the journey of oxygen from environment to tissue is really fascinating. I won't take the whole journey. I will take part of it. I don't go into the details of it because that is not in the purview directly of my talk today. Hypoxemia is low oxygen level in arterial blood or low oxygen content in any tissue or organ. Hypoxia is low oxygen content in any tissue or organ. More important is hypoxia. So what is the level of oxygen? So we can measure the level of oxygen in blood by measuring the partial pressure of oxygen or measuring the saturation. Let's see what happens. How the oxygen journeys to our tissue from environment to the tissue and then back from tissue, how the carbon dioxide is exhaled out. In the environment, there is hardly any carbon dioxide. The partial pressure of oxygen is roughly 21%. If the pressure of the atmosphere is 760 millimeter of mercury or so, it comes around 160 millimeter of mercury. As it gets into the lungs, it is exchanged with carbon dioxide in the lungs. And in the arterial blood, we find the PO2 is 100 millimeter of mercury and PCO2 or partial pressure is 40 millimeter of mercury. As the blood goes to the tissue, the oxygen is taken up, carbon dioxide is released, and in the venous blood, we can find the PCO2 from 40 has been raised to 46 millimeter, and oxygen has dropped from 100 to 40. It has dropped 60 millimeter, and the carbon dioxide is raised by 6 millimeter. And this blood is ejected to the lungs from the right ventricle, where it exchanges with oxygen, and again oxygenated blood reaches the left ventricle to be ejected into the body. And this circuit goes on and on and on. Now let me come to a small bronchus. See, oxygen has entered from our nose through our trachea, airway to the bronchial tree to a small bronchus, and this is a zoom view of the bronchus. You can see the bronchi are divided and subdivided. Ultimately, they end up into sacules like spaces called alveoli. These alveoli are interconnected, and in one surface of the alveoli there is air, and the other side, the outer side, is wrapped with capillary made of pulmonary artery and pulmonary veins. The pulmonary artery carries deoxygenated blood. That's how it is blue. And pulmonary veins actually carry the oxygenated blood. It is red. So there is a huge surface of capillary and environment being separated by a capillary, by a membrane. And this is a schematic picture again. Here, this can actually represent an alveoli or can represent a whole lung. And this capillary can represent the whole perfusion, where you can find oxygen is getting in and carbon dioxide is washed out. Here, the atmosphere, and this is human body. There's pulmonary capillary. These are the epithelial cells in the alveolar wall, and there is a space in between. This is a space, and this space is interstitial space. This space is also important because we know in certain diseases, the interstitial space is disturbed, it is thickened, and the patient has got problem. This is alveolar gas equation, which is not directly very much related to our today's talk, but it is an effect of encouragement by Dr. Gupta last week, where he showed 3 important, wonderful cases. And this is important for us to understand that with a FiO2 or fraction of oxygen in inspired air, 21%, we have got a alveolar gas, partial pressure of the alveolar gas that can be calculated. We cannot measure directly. We calculate the partial pressure of the alveolar gas with this formula. And this is about 110 millimeter of mercury. And partial pressure of arterial blood is somewhat close to it, which is maybe 5 to 10 millimeter less. So it is around 100 millimeter of mercury. But we do not measure partial pressure. This calculation and all are a little difficult. So we follow a ratio of PaO2 by FiO2 in our day-to-day practice. And this gives us an idea how much healthy or unhealthy is the whole apparatus is, where the ventilation, perfusion, and diffusion goes on. I'm not separating the 3 functions of the lung, but this PO2 FiO2 ratio is very important. PO2 is variable. P alveolar oxygen is variable on several factors as water vapor pressure, carbon dioxide partial pressure, underlying physiological state, and its measurement is indirect. So this took me to think about the alveolar partial pressure of oxygen in Lhasa, which is about 11,800 feet, and also that of Mount Everest, which is where the partial pressure is about 266 millimeter of mercury. And with that low partial pressure in the alveolar air, you can imagine how low it will be, the partial pressure of arterial blood oxygen. And with that low partial pressure of oxygen in the arterial blood, people tend to climb without oxygen. So how far adaptable, how greatly adaptable is our human system to hypoxemia and physiological stress. So with this, let me come to the causes of hypoxemia. These have been already discussed last week, so I will just make a few slides. See, left heart and right heart. They are as if 2 different hearts. Not so. The right ventricle and right atrium from the right heart, and the left atrium and left ventricle from the left heart. But they are opposed together. And you can see there is an interatrial septum and interventricular septum. So hypoxemia, I mean, because of less oxygenated blood in the left ventricle, because this blood is ejected in the arterial system. So if there is less oxygenated blood out here, it will cause less oxygen in the arterial blood. And this is possible from intracardiac shunt. This is intracardiac shunt for any reason. If there is a sort of hole in the interventricular septum or interatrial septum, and the right atrial or right ventricular blood pours in to the left ventricle or left atria, then there is an admixture of deoxygenated blood with oxygenated blood, and that will cause hypoxemia. But this is cardiac problem. This occurs only if the right ventricular pressure or right atrial pressure goes higher than the left-sided pressure. But in pulmonary pathology, there are a lot of things can happen. There may be an intrapulmonary shunt, where a precapillary vessel actually shunts the capillary, bypasses the capillary, and drains directly into the pulmonary venous system. So this we can find pulmonary AV fistula and other pathologies. So this is intrapulmonary shunt. Here you can see there is obstruction in the bronchus. So this lung is ventilated less. So there is wasted perfusion. The perfusion is okay, but the ventilation is less. So there is a vacuum mismatch. This is wasted ventilation, where we can find that the pulmonary artery is blocked partially, maybe because of thrombus. So this is increased dead space. This is a ventilation perfusion mismatch situation where there is a consolidation, and similar things can happen in pleural effusion, in pneumothorax, in cases of say pulmonary edema, where the color I have turned is different, and it may be in pleural thickening and other deformities. So the causes of hypoxemia may be listed as hypoventilation, which can be central, neuromuscular structure, or airway narrowing. There may be VQ mismatch, shunt, diffusion defect, reduced FiO2, or in high altitude. And these two pictures are very, very important, where you can see that this, on the left-hand side, the alveoli are poorly ventilated. So the blood is deoxygenated blood passes off directly and mixes with the oxygenated blood. This is a shunt. And here the alveoli are ventilated, but the blood vessel is blocked. So there is no blood flow. There is a physiological dead space. It is not taking place in gas exchange. So actually this space is dead functionally. So this is increase in physiological dead space. This is for the postgraduates. If a question comes, causes of increased alveolar arterial oxygen gradient. Well, the three causes are VQ mismatch, shunt, and diffusion defect. Other conditions that can lead to hypoxemia, they do not change the alveolar arterial oxygen difference. The body is a great buffer. The body has got enormous capacity, enormous reserve to cope up with the stress. In early stage of disease with the ventilation perfusion mismatch or shunt or diffusion defect, the body tries to cope up with hyperventilations. That means the respiratory rate goes up. In resting state, the physiological demand of oxygen is reduced, and the body may somehow manage to maintain the arterial oxygen content just enough to meet the required oxygen supply. So this is very important. So in a patient at rest, it is difficult to assess whether he has got an underlying problem. There may be problems in the cardiopulmonary system, which is not apparent in a resting person. So this to be kept in mind. And exercise is one phenomena that actually exacerbates the physiological impact of this defect. There are defects, but its physiological impact has been exacerbated by exercise. And that can show hypoxemia. So defects are already, I have enumerated. These defects can be exacerbated. And if there is a subtle defect, we can pick it up by looking at the exercise hypoxemia. How to exacerbate the effect of the physiological defect? How does it happen? So coming to back to the previous picture, here is a capillary. The blood flows to the capillary, and this is called perfusion. There is a transit time from this end to this end, and this time is given for gaseous exchange. If this transit time is reduced, the gaseous exchange may be affected. Normally, in 1/3 of that transit time, the exchange takes place. But imagine a condition where the interstitium is filled up with rubbish. There is an interstitial edema or interstitial lung disease. The short transit time may not allow the full oxygenation to take place, because oxygen diffuses much slowly than carbon dioxide, although carbon dioxide is washed out. So there will be no carbon dioxide retention, but there will be hypoxemia. Similarly, on the other hand, if there is a intrapulmonary shunt because of exercise, there will be more perfusion through the shunt. Shunt may widen and a lot more blood may be shunted. The fraction of shunt will increase, so it will exacerbate hypoxemia. So hypoxemia is accelerated in exercise. And this is how we can unmask hypoxemia. Well, hypoxemia has its own definition, and it is either less than expected PO2 or saturation less than 96%, and to some people it is 95%. And luckily, it can be measured by a small instrument called pulse oximeter, which has become a common home article after COVID-19. Measurement of SpO2 gives us an understanding of the degree of hypoxemia. If it is 95% to 100%, this is taken as normal. 91 to 95% indicate mild hypoxemia, 86 to 90% moderate hypoxemia, and anything under 85% indicates severe hypoxemia requiring immediate medical attention. That means if the oxygen level is low, it may not be very well compatible to existence itself. There are shortcomings in this understanding. What are these shortcomings? Ideal definition should include arterial oxygen variation both at rest and exercise. But there's nothing's been said about the exercise saturation. Ideally, the arterial blood oxygen level should be normal even on exercise to a great physiological extent. This is very important. If I exercise and if I have a normal health, and I will find that my saturation will be maintained to a great extent, to a great extent with exercise. As exercise goes on, saturation will be maintained. But after a critical level, it may not be. And that critical level is variable from person to person. Unmasking at some maximal exercise. But this maximum exercise is not warranted, especially for suspected cases of cardiopulmonary disorders, where it may be risky. And there's no reason also to continue that. Here we rather adapt a sub-maximal exercise that should identify and be marked, since that implies significant underlying physiological abnormality. So with a sub-maximal exercise, we will be able to pick up the defect. Hypoxemia will be obvious in patients with cardiopulmonary disorders. This is another aspect which is very important. Sometimes people are found happy with a saturation of 90%, but this has to be kept in mind that saturation of 90% is a false security. Here you can see the oxygen dissociation curve. On the x-axis, it is the partial pressure of oxygen. On the y-axis, it is the saturation. And the upper part of this curve is near flat. So if you see from 97 to 60, roughly 37 millimeter marker reduction in the partial pressure, there is hardly 10% reduction in the saturation. So with a saturation of 90, you may have a partial pressure of 60, or it may be a partial pressure of 95. But if you come down to another 8% or 10%, it might fall to 82, 83, 84%. So just 10% leads to drop of 8%, where here is a drop of 10% with 30 plus millimeter fall of partial pressure in oxygen. So this curve has to be kept in mind. And this is very well elaborated here, that if the partial pressure goes to 40, then the saturation goes around 75%. This curve sometimes moves to the right, sometimes moves to the left, according to different physiological states. But this is roughly, if it comes down to 27, it will be 50%. So if you find a patient having a saturation less than 89% or 85%, your partial pressure of oxygen must be very low. And this may not be compatible for brain to work and heart to function. The patient might develop bradycardia and cardiac arrest. So these are ominous signs. So don't be very happy with the 90% oxygen saturation. You must keep this curve in mind. In normal health, there is hardly any change in saturation with exercise. But in disease state, if the disease is a bit advanced, the saturation may be abnormal even at rest. But in a subtle disease or early disease, the saturation will fall with exercise. Exercise actually unmasks the abnormality that is otherwise missed. So this is unmasking. Hypoxemia may go unrecognized if not monitored once it happens. So this can be in nocturnal hypoxemia, in hypoventilation from obstructive sleep apnea, where you are not aware, you are not measuring, and a hypoxemia is unnoticed. Or if monitored wrongly, monitored at rest, in awake state with SpO2 alone, because SpO2, I have explained the 90% story, and there is another story to it, is the story of hemoglobin. Three things actually maintains the oxygen demand, supplies the oxygen. One is the hemoglobin level, that is a carrier of oxygen. If that is low, then whatever be the status of your lungs and heart, if it is even perfectly normal, you might be giving less oxygen delivery to the tissues. Second is PO2, and the third is saturation. So with pulse oximeter, we measure pulse rate and saturation. Pulse rate actually predominantly is a cardiovascular variable. It depends mostly on chronotropic property of the heart, and it increases in exercise, maybe disproportionately in cardiopulmonary diseases. But on the contrary, saturation, it is a predominant respiratory variable. It reduces in situations of hypoxemia, and it is exacerbated in changes with exercise and in disease states. So SpO2 drops in disease, it means a higher ventilation perfusion mismatch on exercise and can happen in different disease states. So in which conditions the exercise can cause desaturation? Lung disease, heart disease, and pulmonary vascular disease. If there is a heart failure, there will be pulmonary edema, and that will cause vacuum mismatch. It will be exacerbated on exercise. In lung disease, I have already listed, and in pulmonary vascular disease also, there will be exercise desaturation. I always consider my body as a bicycle with two wheels. One wheel is cardiac reserve, the other wheel is respiratory reserve. These two wheels, they are in synergy. And if one wheel is functioning less, automatically the other wheel will function less. This is what exactly happens in our health. Take a situation of a lung disease called COPD. COPD associated with pulmonary hypertension. In early stage, there is more of lung function deterioration. There's a bit of cardiovascular circulatory jeopardy. And together, we have a 60% total reserve being preserved. And with this 60% reserve, the patient may have mild shortness of breath, WHO class 1 or class 2. And only on exercise, he or she gets shortness of breath. But if it is further reduced, and here you can see that jointly, both the circulatory and respiratory reserve is down to 70%, down to 30%. 70% is wasted, lost. And these patients are symptomatic at rest and in mild exercise. This is WHO class 3 and class 4. So in a patient of pulmonary disease and cardiopulmonary disease, we have to look for circulatory and respiratory reserve. The simple way to look for a respiratory reserve is to look at spirometry, which gives an idea of ventilatory status, and DLCO, which gives an idea of diffusions. But there's one more very important part, which is circulation or perfusion. And the circulatory reserve can be assessed by echocardiography, by right heart catheterization, and through understanding of the circulatory response to exercise. And this circulatory response to exercise is very important. And this can be reflected in post-exercise desaturation status and pulse rate changes. So with this, let us take a deep breath, just for a while, try to recap what we have said. We have discussed the journey of oxygen from atmosphere to our arterial blood. We have discussed saturation, means so important to understand hypoxemia. We have discussed hypoxemia. We have discussed the PaO2 or partial pressure of oxygen and saturation relationship. We have discussed unmasking of hypoxemia by exercise. And we know by now that in ventilation perfusion mismatch, in shunt, and in diffusion defects, exercise actually unmasks hypoxemia. So we understand exercise is very important. And finally, we have come to pulse oximeter. We have discussed a little the role of pulse and saturation. We have discussed the reserve in respiratory and circulatory status and how these are changed and how we can get a little bit from our pulse oximetry. Let us some discussion about the pulse rate. We know that it is under autonomic nervous system control and it is initiated by the sinoatrial node. Stress, physical activity, arousal, sleep, etc. They influence heart rate. And this autonomic hyperactivity can be secondary to change or damage the autonomic nervous system. And there is an imbalance sometimes between heart-brain interactions that has a negative impact on the system. I'm not elaborating that, but I'm coming to the response to exercise for the cardiovascular system in terms of heart rate, stroke volume, and cardiac output. Heart rate is our issue because in pulse oximetry, we are getting the pulse rate. If the heart rate is normal, in normal rhythm, then pulse rate actually reflects the heart rate. And you can see from lying to sitting to standing to walking, jogging, and running, how the pulse rate increases. Although this is a trend of pulse rate with exercise, this is a trend of stroke volume with exercise, and this is the trend of cardiac output with exercise. So this is very important. And this trend can give us a lot of clue. Heart rate increases as the exercise goes on. And we have taken that 220 minus age is the maximum heart rate. And this formula we follow in several practices, even in our stress test. There are a lot of literature about heart rate response to exercise. I'm not going into details, but regarding heart rate recovery response, once the exercise is stopped, the heart rate is recovering. It is also important. It is commonly defined that decrease of heart rate at 1 minute after cessation of exercise is very important predictor of all-cause mortality and death associated with coronary artery disease. Such a simple thing. How many of us bother to look at it? We go for so many criteria, lipid profile, coronary angiography, CT, coronary angio, these, that, and so many others. But this is a very simple and very effective prediction instrument. What is the normal recovery of heart rate after exercise? The recovery rate of 25 to 30 beats in 1 minute is a good score. And 50 to 60 beat is considered excellent. And one need to follow it. One should monitor the 1 and 2 minute recovery heart rate at least twice weekly to gauge whether your fitness level is improving or not. So this publication is very elegant and it deals with this recovery rate. And this WebMed publication talks that exercise stress testing and heart rate recovery are the two simple, non-invasive tests to accurately and easily identify a person's risk of having life-threatening bout of heart disease. So important. So there are a lot of literature I found that is available on the pulse rate recovery. But unfortunately, when I looked at literature unmasking hypoxemia, there is hardly any. In fact, people have started looking at saturation now while on or after, just after exercise. And saturation and its recovery after exercise is not that seriously looked at so far. Exercise means a lot to us. The recovery response depends on the degree of exercise, the underlying physiology, and well-being of the organs involved. It also includes the status of exercise adaptation by the system concerned to a great extent. So this is one literature I found using SpO2 recovery index after 6-minute walk test to predict the respiratory related events in hospitalized patients with interstitial pneumonia. This is a very recent publication from Japan in Nature, and it has taken SpO2 recovery index, which is nothing but the SpO2 after 1 minute minus the SpO2, the lowest SpO2 by the resting SpO2 into 100. And they have seen that SpO2 recovery, it actually, in a multivariate model, it has the strongest independent predictor for rehospitalization from respiratory-related events in interstitial pneumonia patients. And a recovery index of less than 4% can be useful in predicting rehospitalization for respiratory-related events. So this means that it can be applied to our patients of DPLD and can predict to a large extent the risk of rehospitalization. So this is also very important information to us. Apart from this literature, I didn't find many. But I found this literature, this WHO post about unmasking hypoxemia in COVID-19 taken from the JAPI 2020 publication by Rahul Pandit and all. And this is an Indian publication. Perhaps this was the first publication of role of 6 minutes walk tests in COVID-19. And it made me feel a little proud, and I looked for the changes. And after that, a lot of literature has come, and this is a warning sign. Warning literature. The people say it has not been yet validated and it may raise safety issues, etc. And this is one latest in the Med archive. It writes an exertional desaturation test should be used in combination with comprehensive clinical evaluation and only on patients whose resting oximetry reading is 96% or above, unless in a supervised care setting. It should be terminated if there is any deleterious effect. So these are all cautious note of cautions, but there are also expansion of these particular finding in literature. So with this, let me wrap up the second part of my story, where I discussed about unmasking of hypoxemia. I discussed about the role of pulse rate and saturation in the recovery phase, their importance, and the fact that saturation recovery or desaturation recovery is not well studied in literature because people didn't look at it. It is so simple. Sometimes simple things are missed, but they're seemingly very important. That literature from Japan about interstitial lung disease with saturation index has been very, very interesting. And of course, we know all that 6 minutes walk test has been used in COVID time, right, left, and center. There was a huge pouring in of information, and there was a lot of chaos in social media as well. There are several exercise tests: 6 minutes walk test, shuttle walk test, seat and stand test, 3 minute step test, squat to stand test, so on and so forth. So people have tried many kind of exercise tests, but 6 minutes walk test is the most important. It includes a global physiological response to exercise. What it requires is a 100-feet long corridor. It should be more than that because the patient has to turn maybe 110 or 20 feet, and the patient moves from one end to the other and turns back and moves back to the previous end and goes back again. And he does it for 6 minutes. There are chairs, he can sit in between, he can stop in between, and we measure the distance, which is the most important variable being measured. And measurement of the functional status is possible by measuring the 6 minutes walk distance in COPD, cystic fibrosis, chronic congestive failure, interstitial lung disease, and peripheral vascular disease. There is utility in impact assessment of intervention in pulmonary hypertension, heart failure, COPD, and after lung surgery. And prediction of mortality is also possible by 6 minutes walk test in heart failure, COPD, and pulmonary hypertension. So it's been so important. But can we do it so freely? But we have a lot of shortcomings. We cannot do. This we felt long back. Once we've been in practice, we feel that 6 minutes walk test is so important, but we cannot do it because 100+ feet long corridor for free up and down movement is not available to common physicians. It doesn't provide insight for the mechanism of exercise limitations. The test allows the individual to set the speed of walking and is affected by a variety of factors unrelated to cardiopulmonary status, such as age, gender, height, and weight. So this is from AJRCCM in 2011, and these all been felt by us. So we need to evolve a new test, need to standardize that new test, need to ensure that it is feasible, easily performable, and can be practiced by most of us easily. Needs to be reproducible and needs to be comparable to 6 minutes walk test, the gold standard. So why this is necessary for us for monitoring our patients of COPD on treatment, not just COPD, because we started the whole business with COPD. That's how I've written COPD, but it is for any patient. Evolving efforts for finding out treatment strategy for COPD PH. Yes, it evolved with us for our COPD PH patients, but it has found many more uses in our day-to-day practice. The test is very simple. But before the test, we had several trials, a 15-yard walk tie test, sit and stand test, walking between two poles, and then we came down to 6 minute walk test, a 2-chair test. In this 2-chair test, 2 chairs are placed 5 feet apart, place to place, and the inclusion criteria is subjects with randomly selected by a physician on the basis of convenience. Anybody coming to the chamber or the office with a cardiorespiratory problem may be selected if it is convenient for the patient and the physician to do. Any subject with the presence of shortness of breath as a major symptoms could be recruited. There are several exclusion criteria, the same exclusion criteria as 6 minutes walk test. Acute myocardial infarctions in the preceding 4 weeks, perceived cardiopulmonary instability on clinico-radiological assessment, gross left ventricular dysfunction in echocardiography, gross musculoskeletal problem, baseline hypoxemia, dyspnea at fatigue, existing cardiac dysrhythmias, and others. And premature termination is done if there is chest pain, intolerable dyspnea, leg cramps, or turning pale or ashamed, or having diaphoresis. So during exercise, our body is involved in exercise and several systems take part. Pulmonary, cardiac, circulatory, hematological, neuromuscular, they all integrate in the exercise activity. But after the exercise, the hematological, neuromuscular, and others, they get quiet and gradually in a very short spell of time. This is a very complicated physiology. I have not been to details of it, neither it is possible for me to explore the area because they demand very sophisticated tests. But we can understand the pulmonary, cardiac, and circulatory functions. They continue and they also gradually settle. And we're actually looking for the changes in pulmonary, cardiac, and circulatory recovery. How this is done, the patient sits on a chair for 30 seconds or so. Once the pulse rate and saturation is stabilized for 30 seconds, then the patient gets up, moves to the other chair, sits, and then gets up to come back to the previous chair. This forms one movement, and thus the patient continuously is doing 5 movements. And after that, the patient sits quietly, and we monitor the pulse and saturation every 10 seconds. This is a list of comparison between 2-chair test and 6 minutes walk test. They're almost similar in their physiological measurement, nature, etc. Both are some maximal exercise tests. Both are relatively safe. And here we have tried this in patients after 6 minutes walk test. with 4 movements, 5 movements, and 6 movements. We have done 2 chair tests, and we have done also 6 minutes walk test. And with number of movements, we have tried to see which one is closer to the changes following 6 minutes walk test. It was a 5 movement that was selected. And we have found that there is no association of either the cumulative change in the pulse rate or the cumulative desaturation with the distance walked. So we didn't bother to take the distance issue in our mind while doing the 6 minutes walk test. And this is a format we used to use for recording the 6 minutes walk, a 2-chair test. And this has been followed in our institute for a long time. This is like an assistant who has filled up, the diagnosis has been given, and the pulse rate and saturation at every 10 seconds is jotted down. See, this dark line, uninterrupted line, is a normal trend. By 60 seconds or 70 seconds, it's normal. And the saturation is hardly reduced, maybe 1% after exercise. But these dotted lines are all abnormalities, and these dotted lines are different abnormalities and different diseases. So it gave us an idea that perhaps the diseases can also be identified. And this is one of our publications in 2015, where we found that in different diseases, the changes are significantly different. So we felt that we must validate this test. And to validate, we have to have a reproducibility and acceptability being tested. So for reproducibility means if we perform the test at different situation, in different time, the tests will be almost same. We choose 40 patients for that. And this is the correlation of the 2 tests being done in the same patient. It is so good, 0.99. This is for saturation, it is 0.98, the correlation index. And you can see there's a fantastic overlap between the 2 tests. So this is highly, highly reproducible. There's no doubt about the reproducibility of that. Then we decided that we'll do some kind of acceptability, because 6 minutes walk test is the most accepted test. We thought that we'll look for the post-exercise desaturation trend in 6 minute walk test, and we'll compare the desaturation after our 2-chair test with that following 6 minute walk test. And here we recruited 60 patients. Here again, you can see how beautifully the 2 changes correlated after 6 minutes walk test and after 2-chair test. And very good overlap also. So it also gave us impressive acceptability. And this paper the findings were published last year in 2020. So we have validation been done. But the important issue to us at that point of time was to look for the utilization in treatment of COPD-PH. I will talk a little about it because our development of this test actually started with the intention to treat patients with COPD-PH. And I'll present you a case to impress that it works. Well, let me come back to the physiology. This is our institutional protocol to give treatment to COPD-PH, where we take in note the functional class. We do spirometry, see the lung function change. We do echocardiography and 2-chair test. And here, more than 3% saturation we take as significant. That means we treat the patients who have got more than 3% saturation. But that's not all. Before giving treatment, there are a lot of exercise. But I'm showing you one patient. This gentleman is a 63-year-old male, non-diabetic, non-hypertensive, long-standing smoker. And he presented to us way back in 2018, where we found the saturation dropped from 93 to 78%. Here in the left-hand side, you can find 2-chair test. This is pulse rate change, and this is a saturation change. And after that, this is September 2018. So almost 3 years before, his lung function was pretty bad, 26% FEV1, remaining same after salbutamol. So it's a non-reversible situation. And this patient's echocardiography outside showed a trivial tear. This is not looked properly. So we had a proper echocardiography. We had a protocol of echocardiography where we looked these things and many more also. The pulmonary artery pressure found was 50 millimeter mercury. TRJ was 3.2 meters per second. LV filling pressure was 10 to 15 millimeter mercury. This is equivalent to pulmonary capillary wedge pressure. So if I have a pulmonary artery systolic pressure of 50 millimeter mercury, it comes around 33 millimeter as a mean pulmonary artery pressure. If I take the upper end of this LV filling pressure as equivalent to pulmonary capillary wedge pressure, So we subtract from 33 to 15, it comes around 18. So it is high. And this is an indication of vasodilator treatment. So this is how we have followed this patient over years. You can see here from 93, it has come down to 87 in one date. In other date, it's after treatment. This was the first situation. When you gave treatment, it improved from 97 to 92. So there was no figure with 80. The patient has improved, and the patient followed with us several occasions, and we have recorded the saturation and pulse rate on 2-chair test. This is one where the CAT score was 16. Later, we changed our proforma to this format. This is now automatic, and we get a curve. We'll show the curve. This curve shows this pulse rate is fluctuating, and the saturation is falling and then going up. So late fall of saturation. After 60 seconds, the maximum fall is there. I think this trend has also some important underlying meaning which we are looking for. And here we can find that the lowest saturation is 81%. This is on, I can't read the date. Well, this is on March 2021. We can find the saturation is lowest saturation is 89%, and I have written poor and compromised recovery response, suggestive of significant problem. You can see the pulse rate going up and then gradually going down, and the saturation going low and slowly coming up. And at this point of time, I looked at the PA pressure again, and it was found to be 55 millimeter of mercury. So it has again increased. So I hiked the dose, and you can see this is on 30th of September. The patient has come again. He has walked to my chamber without any discomfort, and his saturation is 97, 96. The lowest saturation, only 1% desaturation. This is how beautiful is the saturation line, and this is how the pulse rate is dropping. It has turned far healthy. Of course, the patient has been given many other treatment altogether. So, and the CAT score has come down to 9 from 16. So this shows a pulmonary hypertension been treated by us and been monitored on 2-chair tests successfully. And the treatment included treatment of COPD, treatment of comorbidities, treatment of hypoxemia. The patient has been on long-term home oxygen, trying all the best possible rehabilitation, testing 2-chair tests, treating the patient with DSAT max more than 3%, with WHO 3 and 4 staging in functional status, trying sildenafil, building up the dose slowly, and looking for the change of COPD for in CAT score and 2-chair test. This is a publication in which we have shown that our strategy works, where the mean CAT score has changed from 12 to 7.2, a huge change in health status of COPD patients with COPD PH, with treatment being selected on this strategy. But this was lacking hemodynamic support. So we looked for hemodynamics, and we did right heart catheterization in some of our patients. And what we found that our strategy has been correct, because our right heart catheter findings show that the patients with desaturation more than 3% had a pulmonary vascular resistance much higher, very significantly higher than those without saturation less than 3%. And the cardiac output was also significantly lower. Interestingly, the pulmonary capillary wedge pressure in right heart catheterization was similar. So it suggests that these patients have got left ventricular stiffening, maybe because of left ventricular diastolic dysfunction in them, which was present in almost all the patients. And we concluded that COPD PH is predominantly a mixed disease in our populations. So let me come to COVID-19. So COVID is a big story, and it has opened a lot of frontiers to us. And at the initial stage, we were baffled a little, but now we are much more confident. Although we do not know much about COVID yet, but still we know that the challenges are there. We know the ways out, and we know how to deal a patient. The detection of early disease is important. Assessment of severity is important, and for us, the important is assessment of the recovery. Assessment of or detection of post-COVID lung disease and rehabilitations. So pulse rate, pulse oximeter again plays a very, very important role. There may be near normal saturation at rest. One may miss the diagnosis. Desaturation after exercise at one point of time may indicate lung involvement in COVID-19 and possibly the severity of the involvement. The degree of exercise desaturation may help to predict the course of the patient. One need to standardize the amount of exercise. So degree of exercise desaturation. Desaturation pattern after exercise or recovery response may be helpful and may be a useful adjunct and also needs evaluations. You know that a lot of people do not appreciate hypoxemia and they are called happy hypoxemic. And for them, it is important to look for desaturation on exertion. And to see the desaturation on exertion, I've already narrated the 6 minutes walk test is again, brought into this scenario. It is a sub-maximal exercise test, walking in a defined way for 6 minutes. The distance is measured, and there is a lot of prerequisites. But here, remote assessment 6 minutes walk test is a theoretical possibility. It speaks of 3 minutes. A patient may not be able to walk 6 minutes. A patient may not have a corridor at all. So we change the strategy of walking inside the room and going up and down, this and that. But it actually gave a lot of information that exercise unmasked hypoxemia. And in that process, we thought that our 2-chair test will be very apt, because in 2-chair tests, you do not need much space. You have a standardization of exercise. And finally, you have the freedom to stop. And I will tell you how we have done it. But meanwhile, a lot of literature came up on masking hypoxemia and signaling worsening that helps early decision for admission, treatment, and rehabilitations. So, and there was a verdict by the Oxford COVID Evidence Service that an exertional desaturation test should be used with clinical judgment, the same thing, same caution, and only on patients whose resting oximetry reading 96% or above. I tell you frankly, I have treated patients remotely. I was forced to treat, in whom there was no oxygen supply. Saturation was well below 90%. And it is just the pulse oximeter and my common sense that helped, and God helped, definitely. The patient came out. He came later to my chamber. Everyone had similar situations. It was a sort of flood with patients, and our resources were all inundated. And remote treatment of COVID was a reality at that point of time. Although the prevalence of COVID has come down, but we never know. Such thing can happen in future also. So we must be prepared, and we must make a philosophy of treatment later also. So this late detection actually led to late hospitalization, late attention, and improper care or late care related to poor survival. Early detection of hypoxemia is very important. In that case, an exercise unmasking of hypoxemia by 2-chair test should be borne in mind. Let me go to a case story, real world case story. This is Mr. Roy, a diabetic and mild hypertensive, had mild throat pain in June 2020 with nasal congestion. On day 5, he noticed a little shortness of breath on going to bathroom. He was admitted against his desire. He was detected COVID, and he required high flow nasal oxygen, awake prone positions, IV heparin, NIV, and antivirals. And finally, after 14 days, he was discharged. And day 7 post-discharge, he was grossly short of breath. His saturation was room air 96%, pulse rates were 100. But after walking just 10 meters, it dropped down to 93%. So this was a situation. His pulse rate went up from 106 to 130. This is also very important. This is also a sign of cardiac involvement. But you can see the saturation dropping from 96 to 91 in 2-chair test once the patient was that sick. And it even went down to 89%. So we told him, please don't hurry, it will take a long time, and went on keeping his 2-chair test record over the month of June and July. And you can see from 22nd of June to 28th of July, his resting pulse rate has come down from 104 to 90. His resting saturation has been from 96 to 97, slightly improved. His minimal saturation from 89 to 95. Desat max, or the degree of desaturation, came down from 7 to 3, and he was better. And later on, it came down to 2, and from September, he was back to routine activity. So it took him July, August, 2.5 months almost to get back to his activity. Had we have been looking only at the resting saturation, the patient would have been sent to work much early. Perhaps this can cause some long-term deleterious effect, which are not taking into account. Looking at a point saturation at rest. And I charted his changes. As his pulse rate came down, his saturation went up, and his physical activity followed. It also went better. And when I plotted desaturation, desat max, it was somewhat like this in this particular patient. So this kind of association can be made out in n number of patients, and we can form idea from that how a patient should behave. This is the story of Mrs. Kanungo, another lady of 46 years, febrile for 3 days with negligible cough, loss of smell was very important, and her saturation was 96%. Uh, but she was told to do for a 2-chair test on telephone. She knew it because she is my follow-up patient. She did it. His heart desat max was 9. From 96, it's dropped down to 80, 87. But here she had no complaints. He was hospitalized against her desire. She worsened further and discharged after 14 days, now having post-COVID problem. This was X-ray, and this was her post-recovery 2-chair test. This is also important to see because you can see this is 27/9/2020, this is 18/11/2020. Nearly 2 months after this discharge. At the discharge point, oxygen saturation at the beginning of 2-chair test was 95. After first round, 96, second round, 94, third round, 92, fourth round, 94. After 2 months, this has become much better. After fourth round, 94, 95. After fifth round, 90, it is 95. And most importantly, once the exercise is stopped, after 30 seconds of stopping exercise, the saturation came down to 86 at discharge. But here it is 94 after 2 months. So post-exercise recovery response or post-exercise desaturation at 30 seconds and 2 minutes. Here, this has been charted like this. Is so very important. And it speaks much more perhaps than just noting the saturation during exercise. So this is one lesson I got from Mrs. Kanungo. There are many other stories. I'm not going into it. I'm just skipping this. So I had a lot of lessons about using 2-chair test in COVID patients. It's a smart test to diagnose hypoxemia, a smart test to monitor progress and to understand the need for support. Again, a smart test for detection of asymptomatic lung involvement in COVID, test to understand post-COVID lung problem and its scores, and the trend can speak a lot more. Now we have a lot of data. We are looking at it. Perhaps in future we'll be able to speak much more about 2-chair test, its utility in post-COVID situations and recovery and rehabilitations. And for now, we had already placed our views on use of pulse oximetry and 2-chair test in COVID-19 at our website, which is available. I do not know how many people have seen it. We don't have medias to spread this message, but I believe that this is far better than so-called 6-minute swab test at home. And we have categorically written the cautions. We have also guided people for admissions. If there is in future any other surge, God forbid that this may be of use to our doctors and population. So with this, if you are interested about 2-chair test, any of the participants, they can look at this YouTube site for learning the performance, and in our website we have given about 2-chair test. So thank you very much, and thank you with this picture of my beautiful country. I hope all of you stay well, and let COVID go away. Let us have a new life, and let us rejuvenate ourselves and do far more good work for the country. Thank you very much.
Thank you, Dr. Partho. Dr.
Thank you, sir.
Khilnani ji or platform, or he has left?
Sir, I'm not sure.
Okay. Thank you, Dr. Partho. And on behalf of all the audience and from my side, I thank you for your excellent presentation. I will particularly like to discuss 3 things. That one thing about your artistic slides, which is very difficult to prepare for everyone. Second thing, emphasizing the clinical and physiological relations for various problems which we often ignore. And thirdly, for discussing an innovative, that 2-chair test for all of us. we know that it is theoretically it is very easy to say 6-minute walk test, but as Dr. Partho told that how many hospitals have a straight corridor of 100 meter? So probably that's, and I don't know even the West, how they are performing that and what will be the reproducibility and reliability of the test in their contest also. So in that way, the 6-minute test looks very logical and very practical for unmasking the hypoxemia. And even he has told many advantages, but more advantages that it is better for infected person not to travel full corridor. And sometimes when a person have some medical problem, probably it is better that person is doing his exercise in front of us. So in that context, probably 6-minute walk test has many advantages over the 2-minute 2-chair test has many advantages over the so-called 6-minute walk test. Second thing, that we know that if we know the person is having hypoxemia, we can suggest in various precautions. But masked hypoxemia is very dangerous and troublesome than a non-hypoxemia. One may face unexpected problems while doing activities. He do not know that his oxygen saturation is going to fall on exercise. So in this context, various measures which he has elaborated for unmasking the hypoxemia are very relevant. But I will just ask at the end of my short talk that he will say that in what situation in clinical practice one should think of exploring for unmasked hypoxemia in our day-to-day practice, one thing. And second thing, other than what I suggest that whenever we have a patient with some unexplained polycythemia or unexplained pH also, probably those patients should also be a candidate for searching for the hypoxemia in particular situation. Some of the things you have already included about the nocturnal hypoxemia like that. So just can you tell for all of us that in our clinical practice, in our day-to-day practice, in what situation you suggest when to suspect and how to evaluate, you has already told, and some few words about how to manage that this one, unmasked hypoxemia.
Sir, thank you for the question. In fact, these 2-chair tests started with me when I was looking for a substitute of 6-minute walk test for my PH patients. It came spontaneously once we tried that 15-yard walk test, sit up and move test, 2-pole movement test, etc., etc. So finally, when I boiled down to 2-chair test, I found it to be the most easy one. That is how 2-chair test has developed, and I can tell you, once it has sorted out, we started looking at every patient. I made it compulsory for my patients to undergo 2-chair test. And after this publication, and of late, we have made it a sort of apps where it can be collected on a smartphone, and you can get a printout of the trend as I've shown you. I can tell you, although I have not made a statistical analysis, that it has helped me tremendously in my practice. If I find a 2-chair test showing a more than 3% desaturation, there is essentially a definite abnormality in the cardiopulmonary system. Since saturation reflects the pulmonary system more than cardiac, so there is definitely some pulmonary problem. And a lot of our patients have undergone HRCT chest or selected echocardiography just because the 2-chair test abnormality is there. There's no other abnormality. And a lot of our patients have been diagnosed as early interstitial lung disease or pulmonary hypertension. So this has been very important, just not indication for treatment, but also diagnosis of underlying disorder. Now I have integrated it officially in my schedule through ratification by my ethics committee. So all the patients are now routinely being done. And we have seen that trend in COPD, in DPLD, and in asthma, chronic asthma. In normal patients, there is hardly any desaturation. In asthmatics, there could be 1% or so, or hardly 1%. In COPD, the desaturation pattern is little different than the desaturation pattern in DPLD. So these are different fascinating areas we are looking at. And the time of desaturation is also giving some insight into the pathophysiology, which we are also exploring now. Yeah, and apart from that, what I can tell that the pulse rate change is also very important. After we opened up post-COVID, we have looked at the pulse rate changes. And once we found that some patient had this disproportionate tachycardia, then we subjected them for 2-chair tests showing desaturation. We had a selective echocardiography that looked for the global longitudinal strain. So this is an adjunct in normal Doppler echocardiography done in some machines. And this has been grossly found reduced. Some of these patients we had gone for cardiac MRI, and they have myocardial edema, or some 1 or 2 had myocardial fibrosis also. This is post-COVID. So this is another revelation out of 2-chair test. Those who had high pulse rate post-recovery and very relatively high desaturation, I cannot say the measurement of the relativity, but they are slow to improve. And these patients have got essentially cardiac involvement in COVID, which is possibly missed. I don't have any, I have not gone through the literature seriously, neither have published it, but this is my experience, what I'm telling. But of the pulmonary diseases, I request all pulmonologists to look for, to try this. And I'm ready to give the best of my cooperations. And I feel that if we Indians, we get together 5, 6, 10, 20, why not 100 centers together? We pull a data at one place. This is so simple. It's basically free of cost. We can do enormous thing. We can do enormous contribution to our community, because this will reveal a lot of problems. This will help diagnosis of a lot of diseases. It will help us monitoring our patients simply, effectively, without any expenditure. So to my mind, the 2-chair test is a very prospective test for future. And with my limited capacity, I try to encourage everybody to do the test. And this is possibly my first public exposure. Before that, I tried it once for technological glitches. I could not present it. This is what about 2-chair test.
So you will agree, and then all of us agree that the message is that like pulse, blood pressure, temperature, we record for our patient. This to the part of our regular examination in our consultation chamber. So before the patient comes to us, probably our clinical assistant to do all this job, so that we can cleanse the diagnosis more easily, and sometimes the delay in the diagnosis for underlying pathology can be avoided by doing this as a routine practice, as you suggested. So we agree
Right,
with
sir.
that. And if anything from the audience, probably we can invite the questions. If you have any questions in the chat box, probably you can take that.
So I'll request Shayoni or my other colleagues to find out if there's any question at the chat box. I cannot see the chat box at my
We have
end.
a question. We have a question from Dr. Sanjeev Bosha. Sir, please elaborate the calculations you have done from echo report to come to the diagnosis of pH, such as PASP, TRZ max, PAPSI, etc. for PGCs.
Yeah, this is a slightly extended exercise where my echocardiographist is a selected one. I send to him all my patients for echocardiography, and it takes extra care. And there is a format for me individually for reporting. In that, what we look at are detailed parameters for left ventricular diastolic dysfunctions, so that these parameters can be used for publications. Then we looked usually what the people look at. They look at the left ventricular ejection fraction and regional wall motion abnormality, and they feel happy that there is no regional wall motion abnormality. LV ejection fraction is normal. Fine, heart is okay. Well, you are looking at the left heart. You are not looking at the right heart. For right heart, you have to look at certain things different. One is the TRZ, and that is very important. But TRZ is not been found in every patient equally. So there are other parameters to look at pulmonary artery pressure, what my colleague exercises, and he gives a detailed report on that and makes an assessment of systolic PA pressure. There is a formula. to deduct the mean pulmonary artery pressure from that, which is about 0.6 into systolic PA pressure plus 0.2 into the age or something, which comes around for 50, it comes around 32, 33. I've forgotten that formula. From that, we calculate the mean PA pressure. That is quite acceptable. And we have seen, we have tested our patients. We have got about 100 patients right heart catheter done so far. We have found that echocardiography done by him is universally picks up the pulmonary artery pressure. Although the measurement is slightly over measurement been done by echocardiography compared to, but we had a gap of a few days in average between the echocardiography and right heart catheterization. So we are not sure, but I expect that echocardiography result. So in one hand, you get a pulmonary artery pressure, but pulmonary artery pressure, and you have to see what is the transpulmonary gradient. For that, you need to have a pulmonary capillary wedge pressure. So wedge pressure we cannot measure without invasion. So the surrogate of that is left ventricular filling pressure, which can be measured by echocardiography quite effectively. So it does it for me. So it does it for me, and we can see that what is the difference between that pressure, that left ventricular filling pressure, and the mean pulmonary artery pressure. That gives me an idea about the transpulmonary gradient. Plus, in these patients, he looks for the global longitudinal strain of the right ventricle and the left ventricle, or the whole heart together, left ventricle, so that from right ventricular strain, we can get an idea how the right ventricle is performing. That's very, very important. We don't look at it. For all pulmonologists, we must look at the right ventricle, not the left ventricle. Left ventricular ejection fraction doesn't mean much to us. If we have a pulmonary capillary wedge pressure of 19, the left ventricular ejection fraction is 60%. The patient has got may have left heart failure with preserved ejection fraction. If a patient has got a global longitudinal strain being reduced to 12, 13, 14, I have seen 9, 8%. The patient are still thriving, surviving. And these are very bad prognostic markers. It is most important to learn how our right ventricle cope up with the pulmonary artery pressure for pulmonary hypertension. The cardiac output is a right ventricular function, not the left ventricular function. If the right ventricle doesn't work well, the left ventricle cannot work. So look at right ventricle, love right ventricle. This is my sort of understanding till date. And my colleague gives me a lot of information feedback on it. Plus, we have interactions on telephone. If there is a difficult patient, if it doesn't match, his report doesn't match, he takes a little time extra, gets back to his record and gives me feedback. Sometimes we are enriched enormously from that. So that's how I look at my echocardiography, and this is very important. I will request everyone, those who have got access to echocardiography, they should talk to his echocardiographyist. I have talked to him time and again, multiple times. And I have made it that all my patients go to him. The patients sometimes suspect me. I made it 500 rupees less at that center, so that at least they do not look with a suspicion at me. So it happens. People may take it differently. Ultimately, it pays. A lot of diagnosis is unveiled. And this is how I look at my echocardiography. My logistics are very limited. I cannot do the justice to the data I have got with me, or the data I receive. I cannot keep them in proper fashion in most of the time. But I request all my colleagues to start a little bit of that. And maybe in future we'll be doing much more, much better than, and this will be a great learning for us, especially in patients with respiratory disorders.
Thank you again, Dr. Partho, for your informative and interactive presentation. I think we have all liked your presentation. We have loved your presentation. Thank you once again to you and all the audience for today's webinar.
Thank you, sir. It's my pleasure. It's my pleasure that you shared my session, and I have been always enlightened and enriched by your experience. Thank you very much. So we are closing. सर बंद करके फोन कर रहा हूँ.
हाँ बंद करके चलो.
नहीं सर बंद करके फोन कर रहा हूँ.
अच्छा मैं बंद.
ठीक है
सर क्लोज করছি.